You know that feeling, right? You're sitting in the doctor's office, you take a deep breath, and you feel that cool metal disc of the stethoscope press against your back. It's a pretty universal experience, but what's really going on in that moment? Well, today we're going to learn the language of the lungs.
Because they're not just listening for your heartbeat. Nope. They're tuning in to a super complex symphony of sounds, a whole story being told with every single breath you take. And understanding that story, that's an absolutely crucial diagnostic skill. So let's break down how doctors learn to interpret it all.
Here's our game plan. We're going to start with the method itself, the art of listening in. Then we'll figure out what healthy lungs are supposed to sound like. After that, we'll dive into what it means when those normal sounds get weird, listen for sounds that just shouldn't be there, and finally, uncover how even your own voice can tell a doctor exactly what's going on inside.
Okay, first up, the art of listening in. And let me tell you, this isn't just some casual listening. It's a highly methodical process. It's called auscultation.
See, doctors follow a really specific set of rules to get a clear picture. The room has to be quiet, obviously, but also warm, because shivering can actually create its own sounds. The patient sits upright, and the doctor listens side to side, comparing the left lung to the right lung, always looking for symmetry. They start with just normal breathing, and then ask for a deep breath or a cough, which can make those subtle, sneaky, abnormal sounds way easier to hear.
So before we can even begin to understand what's wrong, we have to know what sounds right. We need to establish that healthy baseline, your lung's normal soundtrack.
Over most of your lung surface, what a doctor wants to hear is something called vesicular respiration. And the best way to describe this sound is, believe it or not, super simple. It's this soft, blowing murmur, almost like if you just made the sound of the letter F. F, f, f. That soft little rush of air, that is the beautiful sound of healthy alveoli, the tiny air sacs in your lungs, doing their job perfectly. But there is another normal sound. It's called bronchial respiration, and the difference is like night and day. While vesicular is that soft f sound, bronchial is way harsher, more like the letter H. It's the sound of air moving through your big windpipe, the trachea. Now, what's really key here is that healthy lung tissue is soft and airy, and it actually muffles this sound. So a doctor should only hear it right over the windpipe, not anywhere else. So now that we know what's normal, what happens when those sounds change? You know, any little alteration to that soft vesicular sound is often the very first clue that something might be up. That healthy sound can get weaker for a bunch of reasons. Just think of it like trying to hear something through a wall. Extra tissue from obesity can muffle it. In emphysema, the lung tissue kind of loses its springiness. If you have fluid or air trapped around the lung, like with pleurisy or a pneumothorax, that can totally block the sound. Heck, even a little obstruction or just pain from a broken rib can make your breath shallower, which weakens the sound. On the flip side, sometimes the sound can actually get louder. One special case is called strident or hard breathing. This is a sharp, kind of rasping sound. The big clue here is that the exhale becomes way longer and louder than it's supposed to be. That points to an uneven narrowing of the smaller bronchial tubes, something you might see in a condition like bronchitis. Okay, now we get to the really interesting part, the unexpected sounds. The official name is adventitious sounds, and these are sounds that simply should not be there in healthy lungs. They are the body's clearest clues, little alarms going off. There are three main types of these unexpected sounds that we're going to decode. Rails, which you might know better as wheezes or crackles. Then there's crepitation. And finally, the pleural friction murmur. First up, rails. They basically come in two flavors, dry and wet. And the causes are everything. Dry rails, or wheezes, are those musical sounds. They can be high-pitched or low and rumbling. And they're caused by air being forced through narrowed airways, maybe from a spasm or some thick mucus. Wet rails, or crackles, well, that's literally the sound of air bubbling through liquid in the airways. Just imagine blowing through a straw in a glass of water. That's the sound. And a cough can often change these sounds, which is another great clue for the doctor. Next up is crepitation. This sound is all about the timing. It's heard only at the very, very peak of a deep breath. So here's what's happening. A little bit of fluid in the alveoli makes them sticky. They collapse when you breathe out, and then at the absolute height of breathing in, they crackle open. And unlike rails, this sound is not affected by coughing at all. All right, now for our last unexpected sound. I want you to just listen to this description for a second. Like the creaking of snow, or maybe like rubbing a leather belt.
That sound is the perfect description of a pleural friction murmur. See, your lungs are wrapped in this super smooth lining called the pleura. Normally, it's totally seamless. But when that lining gets inflamed or rough, the two layers actually rub against each other with every breath, creating that distinct creaking sound. And this is happening outside the lung tissue itself. So you might be wondering, how on earth does a doctor tell these similar sounding crackles apart? Well, this table lays it out brilliantly. The pleural friction murmur, you hear it on both the inhale and the exhale. Crepitation, only at the peak of the inhale. And rales can change with a cough, but the other two don't budge. And here's a fantastic little pro tip. Pressing the stethoscope more firmly actually makes a pleural friction murmur louder, but it has no effect on the others. Pretty cool, huh?
Finally, there's one more tool in the kit. And this one doesn't just involve listening to breath. It actually involves listening to the patient's own words to decode the full story. A doctor might ask a patient to repeat a phrase over and over, something like, chess champion. Now, I know it seems weird, but there's a very, very specific reason for this. This technique is called bronchophony. It turns out that sounds like ch and create really strong vibrations. So the doctor is listening to see how clearly those vibrations travel from your airways, through all your lung tissue, and out to the stethoscope on your chest wall. It's all about sound transmission. And here's the key takeaway. Healthy, air-filled lung tissue is kind of like a soundproofing pillow. It muffles the sound, so the words are all jumbled and indistinct. But if a section of the lung becomes dense, let's say it's filled with fluid from pneumonia, it transmits sound much, much more effectively. And all of a sudden, that whispered chess champion is heard crystal clear through the stethoscope. And that transformation from a muffle to a clear word, that is a powerful sign that there's a problem.
So, from the soft F of a healthy breath to the creak of snow and the clear whisper of chess champion, every single sound tells a part of the story. That stethoscope isn't just a tool, it's a way of listening to a language we all speak, whether we realize it or not. The only question is, are we ready to listen?